I'm going to get started. Thank you all for coming for the second ROVER session. It's the Radiation Oncology Virtual Education Rotation. We are having these every other week, and this is our second one. Today we'll be talking about CNS and pediatric malignancies. So next slide. So we'll have each one of the panelists introduce themselves, and we'll start with Dr. Page.
If my unmute button works, can everyone hear me?
Yes.
Yeah, thumbs up. Well, I'm so excited that everyone's here. I'm an assistant professor at Johns Hopkins. I do CNS and head and neck, but CNS is one of my very favorite things. So I'm excited that you guys are here.
Next would be Dr. Gibbs.
Okay. Hi, I'm Dr. Iris Gibbs. I am a professor of radiation oncology and professor of neurosurgery here at Stanford Medicine. And I do quite a few things here. I am also an associate dean for MD admissions, and in radiation oncology, I have helped to build our CyberKnife radiosurgery program, and I do pediatric and adult CNS. So great to be here.
Wonderful. Dr. Kumar.
Hey everyone, excited to be here. So I'm Kiran Kumar. I'm a fairly new faculty assistant professor at UT Southwestern. I trained at Stanford, so Dr. Gibbs is my mentor and former attending, and trained with Archie and other people. So I treat predominantly peds and lymphoma at UT Southwestern, but a little bit of CNS. I'm also the associate program director of the residency and involved with the medical student clerkship. So I'm excited to be part of this.
Dr. Jaboyne.
Hi, I'm Jerry Jaboyne. I'm the vice chair in CNS and pediatric, actually not for very much longer, actually, CNS director for radiation oncology here. Great to visit with you.
Dr. Fivash.
Hi, I'm John Fivash. I'm joining you from Birmingham, Alabama, at the University of Alabama in Birmingham. I'm the vice chair for radiation oncology. I do a lot of radiosurgery, primarily an adult radiation oncologist. I do treat some pediatric CNS tumors as well. I'm excited to be here with you today.
And Dr. Bronstein.
Hello, everybody. Steve Bronstein from UCSF. I'm an assistant professor. And I treat adult and pediatric CNS as well as pediatric non-CNS, and I dabble in sarcoma. I'm very much looking forward to being a part of the panel.
Wonderful. We will have two resident moderators who will also introduce themselves. We'll start with Dr. Miller.
Hi, everyone. I'm a PGY3 resident here at Stanford, finishing up my second year of clinical radiation oncology and then entering a research year next year.
And Dr. Obaid.
Hi all, my name's JP. Same year as Jacob, same class as Jacob. Also going into research year, which we're looking forward to, and happy to moderate this session.
And with that, I will hand over the reins to JP and Jacob.
And this is Archie. Just before we get started, I wanted to remind everyone we're going to be having poll questions throughout the session, so please participate, and please use the chat feature if you have any questions throughout the session. We'll be fielding those as we go.
And with the chat session, reply to all attendees, not just to the panelists, please.
Okay, so we'll go ahead and get started. Our first three cases are going to be CNS, and then our next three cases are going to be peds. So the first CNS case goes as follows. A 45-year-old woman with no past medical history presents to the emergency room with gait ataxia, nausea, vomiting, and some blurred vision. So on physical exam, she's revealed to have some gait ataxia, which was also on her subjective, with instability, finger to nose difficulty, and dysdiadochokinesia. So addressing the question to the panel, what would be your thoughts to typically obtain next on the H&P and potentially even next steps for your management or workup of this patient?
This is Iris Gibbs. I would just say that a young person, 45 years old, who otherwise is healthy and has these what sound like very cerebellar functions, dysfunction, would absolutely need sort of further evaluation. So would not sort of dismiss this as something not to be concerning. So most certainly doing a very thorough H&P, which you've already provided the findings of. And perhaps a battery of laboratory tests to make sure that there's nothing else that's going on, like some weird infection or whatever, or some kind of metabolic disturbance. But because of the cerebellar function, dysfunction, I would absolutely want to get some brain imaging.
Exactly.
Hey, this is Brandy Page. I think in your history, you should certainly ask. This is a 45-year-old woman, and you should make sure she isn't pregnant before you think about any kind of treatment. Ask her about a smoking history. Maybe even ask about cancer history or cancer screening. Is she up to date on her mammograms? They should start those at age 40. And if she has any soft tissue or connective tissue diseases, or as radiation oncologists, we always are worried about someone that might have lupus or scleroderma, and always ask about that in your medical history.
Yeah, exactly. So those are all very good points. She ends up getting a thorough H&P, and for the brevity of this presentation, she does indeed get a brain MRI, as Dr. Gibbs suggested, which shows the following. So we'll kind of just leave it pretty vague and start with a, please describe your imaging findings and what you would be suspicious for given this representative MRI slice.
I'll tell you what I see. So first thing we want to know is what type of MRI we're dealing with. This looks like it's being contrast sequence. And this is basically imaging leaking blood vessels. And so in the right cerebellum, we have a contrast enhancing lesion, looks like a tumor. And then to classify these further, you want to know, is it arising in an intraaxial or extraaxial location? This looks like probably a metastasis or a primary glioma in this area. There's other enhancing tumors that this could be, but it doesn't appear to be rising from a dural surface, so it is an intraaxial lesion, and there's a list of tumors, and certainly metastasis would be pretty high on the list for something like this.
Yeah. And then there's some other sort of weird findings that we can see on here, and much of those are just red herrings, like artifacts. There's a little pulsation artifact over here on the left, but that one most likely means nothing. There is, one can tell, a fair amount of mass effect, because what we would see is the fourth ventricle, but that one seems to be obliterated. And we get a hint of this vasogenic type of hypointensity here, which likely corresponds to edema.
Exactly.
So typically a radiologist, a really good neuroradiologist, the longer their report is, the more anxiety it generates, which is great. And on that report, you'll usually see a differential diagnosis. And, on that differential, it's going to be, a tumor of some kind, and those could be a metastasis or a primary tumor, or even a lymphoma, a CNS lymphoma. So that a very important concept there is to think about whether you want to, if the patient's symptomatic, whether you're going to hold steroids. We'll talk about that later. I know that's coming. Or whether you're going to biopsy an area first. I know there's some other imaging that you're probably going to show. But my point to share this is that there's going to be a differential diagnosis. If one of them is tumor, one of them is infection, one of them is lymphoma.
So that's a very good point, Dr. Page. So what ended up happening was she was started on steroids, which isn't the ideal management technique if you are suspecting a lymphoma, because that would sometimes sort of get rid of it, and you would have a tougher time pathologically differentiating what it could be.
But I would say that this one would be unlikely to be lymphoma in the cerebellar location with some of the sort of edema that's there. So I would have thought it would be okay to spread steroids.
So she ended up getting it before she came to us, and us being the general teams, including neurosurgery. So the question is, what would you do next? And she was symptomatic from this, but it does sort of look like a metastasis. So there's a couple options, and this is a general poll.
Let's see what they say.
Great. So the majority of attendees said it might be a good idea to obtain systemic imaging. And so we can advance the slide, and that's a great idea. So she did end up getting a CT of her chest, abdomen, pelvis to look for a possible primary, because like Dr. Fivash mentioned, this does sort of look like it could be a metastasis from another region, and she's otherwise young and healthy. So it's a good idea to make sure she doesn't have disease anywhere else. So this is what we end up seeing. And the radiology report said that it showed a left hilar mass with lymphadenopathy suspicious for nodal metastases. So going back to the panel, what would be your recommended step for a management next?
So now that you've had a relatively complete workup in terms of staging and history and physical, this is a good time to start getting tissue. And you can get a tissue by doing a bronchoscopy here. But given that you have a symptomatic lesion in the brain, it would make sense to get tissue from there and kind of solve two problems.
Exactly. So she did end up, exactly like Dr. Jaboin said, getting a cradiotomy for resection because it would help stage her sort of maximal stage, which would be metastatic. And pathology did indeed reveal a metastatic lung adenocarcinoma, EGFR mutation positive, which is sort of what you would expect to see in an otherwise young and healthy woman. And so the next poll that we have is, what would you recommend with respect to her intracranial management?
Just so you guys know, while the med students are voting, these are impressive questions for med students to know. And a lot of them are right answers. So don't worry about what you vote. It's actually really advanced stuff. It's really good.
So while we're getting these collections, there was a question in the chat box that says, what about the imaging suggests metastasis? How does a metastasis look different from a primary tumor? The reality is that we need tissue because oftentimes they look exactly the same. Every now and then you can tell a little bit of difference because of the more erratic looking nature of some of the higher grade glioma tumors that might have ill-defined borders. This one felt like it was more like a metastasis because it was much more rounded. And so that was probably why we were leaning in that direction. But you need tissue off to be able to tell the difference.
And I'll just add that one additional for infection, you can maybe see a rim of like dark enhancement. So kind of a hypodense region around it that might be suggestive that this could be infection, TB, or something like that instead of a primary tumor or metastasis.
Exactly. So most of our poll results are consistent with correct answers with an S because there are plural. So stereotactic radiosurgery as well as starting systemic therapy with tyrosine kinase inhibition are good ideas. We can maybe go to the next slide. And so the treatment is, from our perspective, to proceed with postoperative SRS, which is stereotactic radiosurgery. And she did start osimertinib with medical oncology, which is a particular type of tyrosine kinase inhibitor that targets EGFR mutations, specifically one in particular. And then in order to proceed with the SRS, she got her CT head and stereotactic MRI simulation scan. So this is what we see, the top row being the CT portion, the bottom row being the MRI portion. And to answer some of the chat questions about whether it was an R0 resection, the bottom portion didn't show evidence of residual masses to our knowledge. So sort of going forward and asking the panel, please provide your thoughts on target volumes, possible dose fractionation schemes, and critical structures to spare as we treat this patient.
Okay, so firstly, this is a treatment approach that has evolved over time. And we started doing this some years ago. Otherwise, that whole rate of radiation would have been potentially a standard, particularly since there was a survival advantage with just single metastasis being resected with the RTOG study. So, but in our setting, what we would do is we would identify the cavity. And there is still some debate about how long to wait after surgery to be able to do this, because the dynamics of the cavity do change. So we usually will do this somewhere between 2 and 4 weeks or so after the surgery. Larger cavities have a much more gratifying effect in terms of reduction. Smaller tumors really don't change that much in terms of the volume that we might have. The important questions here, because this is very technically more difficult than it had you done pre-operative radiosurgery and then resect the brain metastasis later. When you're dealing with a resected cavity, it takes definite expertise. You want to identify, what did the tumor look like before surgery? Was it entirely interpermeable, as it was in this particular case? And was there any attachment to the dura? When I look at the slice that you gave us, there was no clear attachment to the dura, and it looked like it was entirely interparenchymal. So I would focus on identifying that resection cavity and the surgical tract, and I would give very little margin along the dura to identify that target. With regard to dose and fractionation, there's emerging data to suggest that fractionation of these cavities have, in a recent meta-analysis, yields better local control than single fraction. So I would probably do multiple fractions just like you did here.
And I would just add that for these patients, it came up in the chat, what about an R0 resection? So as Dr. Gibbs said, some of the most challenging part of our decision-making process is whether to treat or not to treat. And even for patients who have a complete R0 resection with no evidence of microscopic disease, as Dr. Gibbs mentioned, there's still evidence very strong to support the use of postoperative radiation in this setting. So this is someone who we would treat irrespective of extent of resection.
I've got a few comments also. I think some of the things that Dr. Gibbs brought up are real. There's a lot of variability in the way people would define the target here and what they would subsequently need to use in terms of the radiation dose schedule. Some people, the target is as small as only the cavity, not treating any adjacent dura or any of the surgical tract. And others will treat something larger. Here you can see a 2 millimeter margin was added, and it extends all the way out to the surgical tract surface. There is a randomized trial of 1 versus 3 fractions that is active right now. So I think the ideal dose schedule, other than being safe for smaller targets versus larger targets, we really don't know the absolute answer to the ideal dose schedule.
Dr. Gibbs, I think you're muted if you're talking.
I'm sorry, I'm talking. I said I forgot to add that I would actually add a 2 millimeter margin, but that question is really based also on what immobilization you have for your patient and what's the reliability in terms of accuracy and precision of your treatment platform. But probably a 2 millimeter margin postoperatively will help to, preoperatively you probably don't need any margin, but postoperatively you need probably at least 2 millimeters.
JP, are you still on the line? Otherwise, we'll proceed to the next case. Okay. So just in the interest of time, we'll proceed to the next case, which is also a CNS case. This is a 62-year-old man who presents to the emergency room with weakness, confusion, and headaches. Again, a neurologic exam was performed, showed a wide-based gait with no specific focal neurologic deficits, labs run remarkable, and the following non-contrast head CT was performed. So here's the head CT going from the top of the head down. And radiology noted a 6 by 5 by 4 centimeter right frontal brain mass. There was right to left midline shift, meaning that the tumor was pushing the brain over to the left side, and there was mass effect upon the ventricles. As was previously noted in the MRI in the prior case, there was some edema around this mass. And just like the prior case, a CT was performed of the rest of the body to see if there's any evidence of cancer, and there was none. In response to this, an MRI was then obtained. And could any of the panelists describe what they see and what the meaning of these two different slices are, these two different series?
Okay, I will take it. So we have a rim enhancing mass in the frontal lobe causing lots of mass effect. It looks like it either has necrotic and or cystic changes. And so when one looks at the T2 weighted sequence, this one tells us more of the water signal. I always tell people water signal in the brain, so that all those water spaces like the ventricles, et cetera, this one looks very similar to that. So this is probably some kind of cystic type of change in the center. And like you said, lots of midline shift. The architecture is changed quite a bit. You see obliteration of the sulci and right of the brain here. So this one looks something that's intraparenchymal and not something that's what we call extraaxial, meaning something that's just simply pushing the brain apart. So it looks very worrisome to me.
Yeah, so radiology, thank you so much, Dr. Gibbs. Radiology described this as a 7 by 5 by 5 centimeter enhancing right frontal and cystic mass with that edema that we talked about. So for our next poll, based upon this patient's demographics, the workup that's been done so far, and the imaging features, what is your leading differential diagnosis? So I'll just start this. And those choices are meningioma, brain metastasis, glioma, or a primary CNS lymphoma. Okay. We'll share these results. So the 70% of the respondents reported with glioma rather than meningioma or brain metastasis or lymphoma. Again, opening up to the panel, maybe Dr. Bronstein, what are the difference, when you see an MRI like this, weighing into the history, the patient's age, and the imaging features, how do you kind of get an idea before we have a tissue specimen what your leading differential might be?
Absolutely. So as we heard before with the previous case, by virtue of imaging alone, there's still a very broad differential. But we look at the patient who's a little bit older, we would look at lifestyle history to see if they've had anything that potentially lean them towards having a metastatic disease, smoking history, making sure they're doing usual preventative health, family history of various cancers. So given the age of slightly older population, given the imaging findings, now based upon the MRI alone, it's not exactly clear whether this is, as Dr. Fiber said before, intraaxial or arriving from the dura, because it is a budding but falcine component. But the cystic components of this and what might be a more central necrotic component or fluid-filled component might lean us slightly more towards something within the realm of glioma. But it's really another situation where it's not clear from imaging alone. Having pan-staging imaging showing no evidence of another lesion, both within the brain and also within the body, is also compelling for something that's more primary central brain lesion.
Thank you, Dr. Bronstein. So the neurosurgery was consulted and the decision was made to do a biopsy of the right frontal mass to figure out what this pathology was. And pathology reported as a glioblastoma, IDH wild type, WHO grade 4, MGMT non-hypermethylated. The histologic features supporting this diagnosis were that there's pleomorphic nuclei observed, frequent mitoses, endothelial proliferation, and necrosis. So just again, opening up to the panel, what do all these acronyms mean? IDH, MGMT, and how do you integrate all of this to think to start thinking about how to manage this patient, or maybe how it distinguishes certain pathologies?
I might have said though that this patient probably should have gotten a resection instead of biopsy, but with all that, but it got a biopsy. We got all these.
Oh, sorry. Yes, they ultimately did get a resection.
Okay, good.
So about 4 years ago, the World Health Organization reclassified brain tumors based on molecular features. These molecular features give us a sense of the prognosis for patients. Oh, look at you. So actually after this, this reclassification in 2016, we almost wanted to start calling these IDH-omas because knowing what the driver mutation causing the tumor drove the outcomes for patients. So patients that we previously thought would have a relatively quick course of progression of tumor might be able to actually have a longer course and have a better survival, but it gave us a better sense of how patients would do. It also adjusted how we treated some patients. So here they have the astrocytoma, oligoastrocytoma, oligodendroglioma, glioblastoma categories, and we eliminated one category, the oligoastrocytoma at this time, and then we used the rest of these features to drive treatments, especially for lower grade tumors.
I'd like to point out that the enzyme IDH is a Krebs cycle enzyme. And for those of you that maybe didn't think that was going to be so important for your career to understand the Krebs cycle, it actually is.
Thank you, Dr. Fiveash and Dr. Jaboyne. So as Dr. Gibbs also mentioned, the patient, following that biopsy, maybe a frozen section was performed in the operating room. The patient has a right frontal craniotomy, so removing part of the bone, and then undergoes a resection of the right frontal brain mass. He recovers uneventfully after the surgery and is discharged. And then a post-operative MRI was obtained on day 1, so immediately following the resection, and it shows the following. So maybe Dr. Fiveash, can you describe what you see between this non-contrast and contrast-enhanced MRI?
Yeah, so we're doing a non-contrasted study to look at surgical blood product, and things that are bright there or on both, we're assuming may be related to the surgery. And what I see is a big hole where the contrast-enhancing abnormality used to be. And so it looks like the patient's had a pretty good surgery. We're also going to be looking at the flare or T2 that was shown earlier to sort of see how that's changed or evolved to decide what we need to treat. One of the things we'll be looking for is tumor crossing the corpus callosum anteriorly and whether that area is at risk. These tumors tend to be bifrontal, and that's how it gets to the other side.
And I will mention as well, I agree with that. This one looks like a gross resection on this slice, but the T2 sequences, either FLAIR or other T2, are going to be really important in these tumors to look at because there may be non-enhancing tumor. And so sometimes people will focus just on the contrast enhancement, but you have to pay attention to that as well.
Thank you. So radiology felt that it wasn't shown on this slice, but there was a near total resection with some post-operative changes. And more inferiorly, there was concern for maybe a little bit of residual enhancing tissue. The patient is referred to your service and you meet the patient in clinic about 2 weeks after discharge. His performance status is 70, his age is 62, and let's say he had a near total resection of this glioblastoma. So that brings us to our next poll, which I'll share now. So at this time, after resection of glioblastoma in a 62-year-old man with a performance status of 70, what might your treatment recommendation be?
Well, I guess I'll take it. This patient has an unmethylated tumor that the MGMT promoter unmethylated, and his prognosis is worse.
Yes.
And so we're going to be thinking about enrolling in clinical trials, which I don't think you had listed here.
That's a good point. Yeah, we should. That's an excellent point to make, and also for other cases that NCCN will also recommend and strongly encourage enrollment in a clinical trial as the first step.
So yeah.
Okay.
Yeah. This patient has a pretty good performance status. The age of 62 is not that old, but it is it's in that age category where you might think about some alternate options. So a clinical trial would be good, but standard treatment would be what I would recommend right now. Standard chemo radiation, concurrent and adjuvant temozolomide with radiotherapy, because of what Dr. Fivesh mentioned, the IDH wild type probably, and no MGMT methylation probably means that there's not huge advantages for other things that we have.
So if this patient were older, like in his 70s, some of us would consider a shorter regimen called a hypofractionated regimen. That's 15 treatments. Yeah. But since he's in his 60s, he's not quite on the cutoff where the clinical trials showed that would be just as effective. So for our younger patients and higher performers in the older group, we tend to use this fractionation regimen.
So as Dr. Gibbs mentioned, this would be sort of like the standard course of therapy for a patient of this age with a reasonable performance status, radiation with chemotherapy over 60 fractions or 6 weeks. So the patient comes back and has a simulation or a planning session in which a mask is made, a CT scan is performed, and the MRIs, both preoperatively and postoperatively, are fused to the CT. I think just in the interest of time, we'll open it up to the panel. Can you kind of describe how at your institution you define your treatment volumes, whether you use margins off of the edema or just the resection cavity? Maybe Dr. Page, we can start with you.
Sure. So, it's very interesting over the years. You med students are going to be in the new generation, so you're probably going to reduce margins even more. So in the RTOG, it's commonplace to use a 2-centimeter margin, and that's what a lot of protocols use. Over the last several years, many institutions have reported efficacy with reduction of margin, and it does reduce some toxicity if you can do that. At Hopkins, we use a centimeter. There's a couple of us use a little bit of variation, but it's a centimeter of a clinical target volume, the CTV, on the T1 post-contrast, resection cavity and anything left over. And then on the FLAIR sequence, we will use that, we'll combine those to a 46 gray and then boost the contrast enhancing volume to the 60. And our institutional margin is 3 millimeters, and that's based on recommendations of uncertainty from our physicists who analyze the machine and how good our image fusion is and what's our uncertainty. So that's what we would do.
I would add, I think I always teach my residents, we're talking about what I call intelligent margins, and that's what we sort of do with all of the sites. You have to think about the behavior of the tumor, and here along the falx, you see that the margin is not really that much there. Even if you were using 1 centimeter margin, you wouldn't extend too much because you're not expecting that tumor is going to invade it to the opposite side. But in the region of the corpus callosum, where the tumor you may even extend your margin even a little bit more. So this is why that one looks like a sort of asymmetric margin that we see there.
Yeah, that's a really good point. And sometimes, no matter how advanced you are, it's a smart idea. If you're not 100% sure, it's always okay for you to go sit with your neuroradiologist and review these scans. Always, 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 it's okay and recommended.
And so using those target volumes, the patient had the treatment plan, which you can see here again, with the radiation dose lines now extending across the corpus callosum. So this patient completed the course of chemoradiation with some fatigue, hair loss, nausea. An MRI of the brain was then obtained about a month after finishing radiation. It showed no just post-treatment changes, which is often commonly observed, no evidence of new cancer in the brain. And then per what was, I think what Dr. Gibbs was describing, again, more temozolomide chemotherapy afterwards. And so just very briefly, we've touched on about a few of the case variations so far before we get to our next case. But maybe just focusing up on the first question, what are some therapies that we can now add to temozolomide chemotherapy after radiation for certain patients?
I think Jerry should answer that one.
I guess I should. I have no choice. I was looking at you guys. So future Dr. Simon Kirch. Dr. Simon Kirch, she just referenced TTF therapy. So tumor treating fields has been not that recently added to the NCCN guideline as category 1B treatment. So these are electrical field therapies that you place on your head that alternate electrical fields to generate a magnetic field that we believe might disrupt tumor growth. So the 2 big trials, EF11, EF14, demonstrated that there was improved survival, and that improved survival was greatest in the group that had hypermethylated MGMT, which is true for almost anything that you throw at these tumors. But if they have that hypermethylated MGMT, they're less likely to repair their DNA. So 18
hey,
hours.
Jerry, can you tell the med students and the residents who might be on here, because there's so many good questions, can you tell them what the TTF is and how do patients react to it?
So, you know, the most common, I'm trying to look for if I have a helmet back here, but you place these leads on your head, and there's 4 leads. These pads kind of coat your head. They're adhered to your head with adhesive. I hope you're not taking a picture of me, Brandy. There's adhesive that attaches to the skin, and you have to have these pads on for about 18 hours a day. There's been suggestion now that increasing the dose density actually improves survival even further. I'm not touching my hair anymore. So you wear this battery pack, and the recommendation is for you to use this for as long as possible per the trial. But the biggest issue, of course, is scalp irritation, especially for people who have not had, not have been involved and having to shave frequently in order to maintain the adhesive to their skin. So relatively novel therapy.
Right. Thank you, Dr. Jaboy.
Anytime.
And here at Stanford, we've also had some clinical trials that involve things like plerixafor, and so we can go into clinical trials area, but for the sake of time, we won't.
All right, and so moving on to the third CNS case, Dr. Obaid, are you there? Well, I'll start. JP, you can jump in whenever you'd like. So this is a case of a 44-year-old woman with no medical history who experienced a 3 minutes shaking episode resulting in a car accident. So patient was brought to the emergency room and imaging was performed. Maybe Dr. Fiveash, could you describe what you see on the head CT and the MRI?
Yeah, so in the emergency room, it's usually easy to get CT-based imaging, and it's quick and can screen for a variety of conditions, including tumors. In the right frontal region, there is a bright signal on non-contrasted imaging with some mass effect. And you wonder, you haven't given contrast, why that would be there, whether it's a hemorrhage or whatever. And then on the MRI, you see a contrast-enhancing abnormality with a necrotic center, and there's not a huge amount of edema around it on the T2. So pretty broad differential. We're still trying to figure out if this is an intraaxial or extraaxial mass to narrow down the differential at this point.
Thank you, Dr. Fiveash. So for our next poll, this was ultimately felt by radiology to be, again, we don't have tissue, we don't exactly know what it is, but felt to be maybe most consistent with a meningioma. So for our next poll, what?
Can I add something?
Of course.
I would say that the image that was shown like has some somewhat atypical features for just your garden variety meningioma. So that one might actually lead me to doing something maybe different. If I'm feeling like the imaging finding is very, very consistent with the benign meningioma, then we might be thinking about radiation empirically without even establishing a diagnosis. But in this case, I would probably not do that.
Yeah, in this case, the bright signal, the C2, would have been calcification. If we
it still could have been calcification, but that whole it looks a little unusual.
Yeah, I agree with Dr. Gibbs. This is a little bit atypical for a garden variety meningioma. For the garden variety grade 1 meningiomas, we usually see them, in the frontal convexity, along the dura, in the cavernous sinus, around the optic nerve sheath, things like that.
And because this was a new diagnosis, patient had no history of any brain tumors. Let's say it was a meningioma and the patient were symptomatic. What treatment might you recommend initially?
This
is a poll question. Yeah.
Okay, I'm sorry.
Okay, so 77% of the respondents recommended.
I think they were influenced by my.
Yeah, yeah. So yeah, surgical resection, and the patient ultimately did undergo resection, and it showed an atypical meningioma, WHO grade 2. So not the most common type of meningioma, which would be grade 1.
Hi, Jacob. Can you hear me?
Yes. Yeah.
Okay, great. I'm back. Sorry about that. It was a whole ordeal. Unannounced internet repairs in the area, but I'm happy to take over. So basically, yeah, she did undergo the resection, which showed WHO grade 2, and listed to the right is a brief sort of synopsis on how we grade meningiomas. And the main one to remember is mostly based on their mitotic rates, so the quantity per high-powered fields or per 10 high-powered fields. So afterwards, she underwent a post-resection MRI, demonstrating a small amount of residual tumor along the sagittal sinus. So at this point, what would the treatment that you would recommend for a subtotally resected WH2 grade 2 meningioma be?
Okay. Okay, stereotactic radiosurgery. Wow. So.
Yeah, please, Dr. take over.
Yeah, I was just going to say that for atypical or malignant meningiomas, radiotherapy would be considered standard. This one, I think probably my surgeons would probably try to convince me to do something like radiosurgery, but I'd probably resist because you do need actually more margins beyond the edges of the tumor. And even though they're like, oh, there's just this little bit of tumor near the sinus, then we would probably still do conventional adjuvant radiotherapy fractionated.
Great. So that would be an ideal segue into potentially the panel question. What would be your thoughts about the volumes that we would use for fractionated radiation, given that the next slide shows her CT sim with the fusion of the post and pre-op imaging?
So maybe just extending on what Dr. Gibbs said before, this idea of intelligent volumes, where we're thinking about the anatomy and we're thinking about the invasive propensity of this tumor. So unlike glioma, these tend to be, even for the grade 2s, they tend to be less infiltrative. And so we're not delineating target volumes that are going to penetrate deep into brain parenchyma. We're restricting them largely to the surgical cavity or the area of the resection at the dural attachments with a relatively small margin, recognizing that there could be some microscopic presence within that region. So these tend to be much smaller volumes as compared to what we saw for gliomas.
Maybe I could comment a little bit about the variability of practice here. In our own series, we had 30% local failure with no radiation, and MIB1 labeling index and pleomorphism were predictors of local failure. So there are lower risk patients that maybe don't need radiation. And there's an Alliance randomized trial looking at whether this is beneficial in terms of a variety of endpoints. We will often stratify patients into higher risk or lower risk based on those risk factors, and adjuvantly treat the high risk patients and selectively observe some patients depending on the comfort of the tumor board.
Exactly. So she ended up getting treated with 60 gray and 30 fractions, fractionated radiation, with the following treatment volumes as well as the dose radiation plan. The one to our left shows a minimum coverage of 95% isodose line, which was actually what the PTV was normalized to, so that coverage was guaranteed. And the one on the right tends to show how that dose gradient falls off, with the minimum being the minimum perimeter being 50% isodose line. So it was rather sharp. And the next slide asks about case variations, which is exactly what Dr. Five-Ash was sort of referring to, the NRG randomized trial. And it asked what if she had a grade 2 but a GTR instead. And sort of in the interest of time, the randomization would be to potential observation versus treatment.
Okay, thank you, JP. So we'll proceed into our first pediatric case, which is a pediatric CNS case. So this is a case of a 6-year-old girl who presents to the emergency room with headache, nausea, vomiting, no relevant medical surgical history. An examination is notable for papilledema and an abnormal gait. And basic labs just show electrolyte abnormalities sort of consistent with dehydration in a patient who's been vomiting. And an MRI of the brain is ordered to suspecting an intracranial mass. So it ended up showing these findings. Maybe Dr. Gibbs, would you like to review these different series and how your differential might be influenced by what you see on the imaging?
Oh, Dr. Gibbs, you're muted.
Yes, I thought I was unmuted. So first thing is make sure you do not hydrate this patient, because we really do not want to send this person emergently to the operating room to get hemorrhage, despite to get herniation, despite the dehydration at this point. So on the imaging findings, the first one shows a most likely, yes, definitely contrast enhancing mass occupying the fourth ventricle. It is somewhat, it is most likely arising from the roof of the fourth ventricle rather than the floor, because I can tell from the T1 pre-contrast axial and this sagittal that there's a nice plane between the brainstem and this tumor mass. So, and then the T2 weighted changes shows that it's a heterogeneous signal there. And so the most likely diagnosis that I'm thinking of right now in a midline posterior fossa tumor arising more from the roof rather than the floor of the fourth ventricle would be medulloblastoma. Other things in the differential would clearly include something like a sort of pilocytic astrocytoma, but which would likely be in a different location within the posterior fossa, an ependymoma, which would usually look a little bit more aggressive and arise more from the floor of the fourth ventricle. So I'm going with medullo on this one.
Thank you, Dr. Gibbs. So the decision was made to proceed with the surgical resection, which is performed. 1 day afterwards, unusually, this girl develops mutism, dysphagia, and emotional lability. Dr. Bronstein or Dr. Kumar, can you comment on what might be happening after this cerebellar surgery?
Sure, I can comment. So, so she's most likely experiencing something called posterior fossa syndrome or cerebellar mutism. So this is fairly common after surgery, like 15, 25, up to 25% of patients will experience it. And it's this symptoms that she has, this mutism, dysphagia, emotional lability. Sometimes they can even get respiratory failure. And this is something that you just really have to reassure the family that will get better over time. And so sometimes it can take months, but you just reassure them that it will improve and you should continue on with your treatment.
Thank you. And then again, for the CNS pediatric panel, after this, let's say it shows a medulloblastoma, what would your next steps for workup or staging of the patient be?
So she needs additional staging workup, in part because we recognize that medulloblastoma can disseminate throughout the craniospinal axis. So as you have posted up there, we need to have postoperative imaging of the brain, which can be done fairly soon after surgery, and then MRI of the spine, and usually wait 10 to 14 days after surgery because of disruption of the blood-brain barrier, and the surgical intervention instrumentation can cause some blood products and other products to appear within the spinal CSF space that could be mistaken for tumor, and then CSF in the same manner as part of staging.
Thank you. And so for this patient, a postoperative MRI of the brain obtained 2 days after surgery showed no residual disease in the posterior fossa, so complete resection of this tumor. An MRI of the spine showed no evidence of seeding or metastases throughout the rest of the craniospinal axis. And CSF cytology with a lumbar puncture showed no malignant cells. No evidence that it spread. We have a gross total resection of this tumor, and the pathology showed medulloblastoma grade 4 of classic histology without any large cell or anaplastic features. And then molecular testing showed that this was a Wnt activated tumor. It was not SHH or sonic hedgehog activated, and MYC negative. So Dr. Bronstein, can you comment on what is your first step in thinking about managing these patients after surgery? How do we break patients up, and what would this patient fall into?
Yes, so for these patients, it's very interesting. So this is an area where things have changed significantly over time. And so we used to recognize essentially 2 risk categories, as you've noted up there, the standard average risk or high risk, that would warrant differential therapeutic interventions. The mainstay of treatment for medulloblastoma is very much a multimodal therapy. It's combinations of safe surgical resection, radiation, and chemotherapy. And what we've come to understand over a number of studies of the past several decades is that a combination of chemotherapy and radiation has allowed us to reduce the doses of radiation that we would otherwise use. And there's still ongoing work in this area that we'll probably talk about. But essentially, based upon the categories you see here for risk stratification, we have standard risk that will allow us to use smaller doses and potentially smaller volumes of radiation therapy as compared to the higher risk individuals where we need to be a little bit more aggressive to achieve potential curative, more durable disease control. But this has changed, and now we recognize that we can further granulate these patients into categories not based upon what is this combination of clinical and gross pathologic features, but with some molecular components. But now we're looking at actual molecular profiling of these subgroups, and we're able to resolve it now into 4 or actually now even more various subgroups of tumor that we can identify different prognostic categories. We can see the biologic behavior as a function of age and molecular subtype. So for us, it's a very exciting time to be able to refine these categories and then refine our therapeutics based upon where the disease falls within these categories.
And along those lines, for our next poll question, the pathology report and the molecular testing showed that this patient had a Wnt-activated tumor. What's the significance of that, and which subgroup of medulloblastoma has the best prognosis? And then while the respondents are answering that poll, Dr. Jaboin, do you want to walk the group through the different subgroups and what their significance are, and maybe in what populations we observe these different subgroups?
Absolutely. So all 4 of these groups are seen in the pediatric population, and as the poll is straight up right, Wnt is the most favorable group. Subgroup within this classification. So here we have Wnt, we have sonic hedgehog, we have group 3, and what I like to say, not the other 3, which is group 4. So right now, what we're trying to determine is for these very favorable patients that have this Wnt-driven pathway, can we dose de-escalate further the craniospinal radiation to potentially reduce late toxicity for patients?
Thank you. So that segues very nicely into the management, and just for the sake of time, we'll discuss what was recommended for this specific patient. So she was enrolled on a clinical trial, the SJMB12 protocol, and because the patient was standard risk but had a Wnt-activated tumor, no residual disease, no metastases, she was treated on the low risk or experimental stratum, treating the craniospinal axis to 15 gray, and then a boost to the resection bed to 51 gray, followed by chemotherapy. So Dr. Gibbs, do you want to talk about the SJMB12 protocol and how your recommendations might change?
Yeah, so we've been treating patients on this SJMB study for a while because we've recognized that the Wnt activated tumors have favorable prognosis, but again, with this one, they can be non-disseminated and have no MYC amplification. So every now and then you might see that happening. So this one has to be clarified by its biology to make sure that there's nuclear beta-catenin signal, staining, and all of the other factors that exclude it from being any higher risk. If all of that is confirmed, then what this study does is it reduces the dose of craniospinal radiation, which standardly would have been 23.4 gray, and on the most recent a completed COG study might have gone down to 18 gray, but in any case, 23.4 gray goes down to 15. And then the boost volume is reduced to 51, from 54 gray to 51 gray. This study also, if you look at the green lines, it identifies this high risk group as well, and this intermediate risk group, which is pretty similar to the other treatments that we've done before, but this high risk group that can be identified by this MYC and amplified, even if you had an M0. So this one is really intensifying treatment for those with drugs that we typically wouldn't even have used for brain tumors, pemetrexed and gemcitabine. for to just look at new directions. And then for those sonic hedgehog tumors, there is a targeted agent, vismodegib, that some patients may be eligible for if they're beyond about 14 years of age, where their bone, their bone growth can sustain the use of this medication. So very interesting trial. The other option on trial, and again, I think the clinical standard of care would be enrollment on a clinical trial for this patient. And the other clinical trial would be the COG trial that probably just opened, just got approved in November, is looking just at Wnt tumors and reducing the dose to 18 gray, but still giving the boost to 54 gray. So for this patient, enrollment on a clinical trial would be the treatment of choice.
Thank you so much, Dr. Gibbs. And then, so we've mentioned craniospinal irradiation a little bit, and Dr. Bronstein touched on why we even do this for medulloblastoma, because it can disseminate throughout the craniospinal axis. Opening up to the panel again, can somebody describe what are the various techniques that we can actually treat a patient like this, and why do we even talk about craniospinal irradiation and the treatment planning?
I guess I'll start by saying it's hard. It's technically challenging, among the most challenging types of treatments we do, in part from really a technical ability, historically, with the consideration of having to treat, even for a small pediatric patient, a very large volume of tissue, and the brain and the spine, even though we can think of our bodies as big bags of water. To be able to deliver this type of radiation requires some fundamental recognition of how the photons, we'll start with photons, the beams are generated and actually deposited in tissues. And so we have these linear accelerators that are generating these high energy photons, and they are filtered, they are shaped, but as they emerge out from the machines, they will undergo some amount of dispersion, and we can see that here. And so as the beams emerge, they're depositing in such a way that we have to be very thoughtful about having multiple fields and aligning them in such a way so that we don't over or underdose them. So it's almost like patchwork in some ways. And historically, that's very challenging, and we have to have a very strong fundamental of geometry to be able to match what we call divergence among matched fields. And that's what you're seeing here to create what we hope is to be a fairly uniform dose deposition. And fundamentally, within the abilities that we have, there's always some heterogeneity. There's always what we would call hot spots or cold spots where dose is high or low, and that can create issues in terms of undertreating or overtreating and causing harm to patients. And so this is a very technically challenging type of treatment.
Oops, sorry, I was on mute. And so at each of your institutions, how do you practically treat patients with craniospinal irradiation? Do you treat them on their back, or with the traditional 3D planning, VMAT planning, and how do you decide how far down the spine to treat, and why do you do that?
So I can tell you about the Stanford technique, which has evolved over time. Trying to treat patients prone is probably the most straightforward way of knowing that your fields actually are indeed being delivered sort of accurately. But that one is really difficult if you have a patient under anesthesia. So fairly early on, when I was an assistant professor, and I then switched to a technique where we would treat patients supine, allowing for good anesthesia, but you would have to develop alternate ways of being able to check your field matching, which we're able to do. But ultimately, I felt like I was getting a little dissatisfied with the dose distribution, because the doses were a single posterior field, which would give a lot more dose than I believe necessary to the abdominal structures. And certainly in the face of alternative treatments like proton therapy, we had to really evolve with our X-ray techniques to be able to mirror some benefits there. So we have worked to develop a VMAT technique, a volumetric modulated arc therapy technique that actually simulates, at least in the high dose planes, simulates the dose distribution that one could get with protons. Now, the low dose ranges, there is a little bit more low dose spill, but much less so to those organs than we would have with conventional single PA. So the image you showed previously was one of our fields, the one with the dose distribution was a VMAT plan. Now that one is achieved by actually overlapping to be able to get what we call dosimetrically matched fields to get a uniform distribution throughout the entire spine. So this is quite gratifying. It is still technically challenging as well, but we feel like that this one's going to give much better outcomes for our patients.
And then kind of touching on the reason why why do we care so much about this? Obviously it's technically challenging, but what are the benefits of even doing it properly or making sure that we reduce dose to the abdomen or reduce dose to the cochlea? Dr. Jaboin, can you comment on what are some of the acute or late toxicities that we counsel families for, and how can they be mitigated with various different radiation techniques?
So let's start with acute toxicity. Sorry, of course I messed up my screen here. But acute toxicity, with these long lengths of irradiated fields going through bowel, your patients have difficulty with nausea, vomiting. We can pre-treat them, but typically there's loss of appetite during this long course of therapy. Fatigue is the most common side effect. So kind of all the traditional things, just worse. In terms of late toxicity, someone already mentioned here secondary malignancy. Given the large volume of patient treated, there's a high risk for secondary malignancy in this population. One of the reasons that people consider the use of proton therapy so valuable is to mitigate that risk by just reducing the total volume of irradiated tissue. At our institution, we've been using tomotherapy for the last decade, which has a ability to deliver a very good high dose region, but a lot of low dose spill. So for patients like that have that low dose spill, they have potentially, and again, this is all potential, significantly higher risk of secondary malignancy. So something that we have to be concerned about. On the screen that you demonstrated, which I can't get back to right now, I'll get there. The idea of trying to be a bit more conformal in the posterior fossa because of risk of ototoxicity. The platinum agents that are already used on the chemotherapy side of this can cause this, but by overlapping the cochlea with radiation, of course, you increase that risk potentially further. In cases with patients with large posterior fossa tumors, you might not be able to get away with being too conformal in that region. But that, again, that's another risk. Thank you. So I think we've touched on this last question of, when can dose be reduced? How does dose change, whether we have a standard risk patient or a high risk patient or maybe different molecular subtypes. And then we won't cover this specifically, but suffice it to say, infants with medulloblastoma do have a different type of management because of those long-term risks of radiation at an early age. So we'll move on to the next case, Dr. Obaid.
Sure. Alrighty, case number 5. So the presentation here is also a pediatric one. It's a 5-year-old girl who's referred to us after her pediatrician palpated a firm abdominal mass on routine physical exam. So let's go ahead and ask Dr. Kumar, what would you like to know further on HMP and any additional workup that you would like to do for this 4-year-old girl with an abdominal mass?
Sure. So, this is a common presentation, a common thing that we get asked about. So if you're a young girl, pediatrician, they know it's a mass. The first thing you want to know is what are the associated symptoms? So how is the child doing? Do they look well and otherwise feeling well and just found the mass, or are they sick? Do they have fevers and weight loss? Is this mass painful or not? And then on physical exam, really just looking at other abnormalities. Obviously, we're in the oncology world, so you're already thinking about differential and then thinking about associated symptoms with the things on your mind. But really just on physical exams, if there's anything visible in terms of things like aniridia, hemihypertrophy, any large organs, genetic defects, and then we're moving on to the workup. In addition to the H&P, normally the next steps would be to get some labs. So you would do a CBC, CMP, probably a UA, and then eventually go on to some imaging.
Exactly. So for her, she ended up getting a abdominal ultrasound first, which did confirm the mass. But what's sort of more relevant to help better characterize things, she ended up getting this abdomen pelvis CT. So we'll defer to the panel to please sort of let us know what you see on this and what tumor may you be suspecting.
I can comment on this too then. So for med students, when you start off and someone shows you an image or a slice, first thing you want to see is what are you looking at? So in this case, this is a CT scan, right? And so you can see the vessel, the aorta that's bright. So this is a CT with IV contrast. You're looking at an axial slice. Try to orient yourself and see where you are. And so you can see that you're in the kind of the upper abdomen, the liver is anterior, you see the stomach on the left side of the patient, you can see the spleen, the kidney, so just kind of get oriented. And then obviously you turn your attention to the big thing that's kind of shouting at you, which is on the right side of the abdomen. So here you see this large, well-circumscribed mass, solid appearing, it's heterogeneous. It kind of looks like it's arising from the kidney, and other things are, it's on one side of the abdomen, so it's not crossing the midline. There's no calcifications or things of that sort.
Great, thank you. So this slide is basically an attempt to kind of differentiate between the two main differential diagnoses that we have, the Wilms versus neuroblastoma. And I think if we populate the red arrows, it should point out several things that Dr. Kiran Kumar mentioned, actually. So the two lateral ones are the neuroblastomas, and the one in the center is Wilms, which is what we see now because it directly grows out of the kidney and it doesn't cross midline. So the poll would be, what would be the next step since we suspect the Wilms?
Right.
Great. So perhaps the panel can let us know. It seems like the poll is split amongst surgical resection, and some think it might be a good idea to biopsy because that's a general principle in oncology. Perhaps the panel can inform us as to why surgical resection would be preferred in this case.
Okay, I can comment on it. So in general, we try to avoid biopsies, at least here in the US, for Wilms tumor, if we're suspecting a Wilms. That kind of gets into the management of Wilms. When you biopsy, it upstage them to stage 3, and then that affects how you treat them. And usually that means you have to do radiation, while early stage Wilms, you don't need to do radiation. So really based on imaging and your history and physical, if you suspect a Wilms, surgery is the answer and not biopsy. Also, that that's the treatment for it. They need to get surgery. And so, you just go straight to that step.
Great. So she's taken a surgery and undergoes a right radical nephrectomy, which is the main operation you want to perform, as well as a lymph node sampling with abdominal exploration. So the next poll that we have is which of the following from surgery would be an indication for adjuvant radiation for Wilms?
So as they're answering that, I would just say, I just wanted to add that for us in radiation oncology, the case of Wilms, I think really highlights the importance of knowing surgical findings, understanding detailed findings from pathology, that you're never ever making a decision here without a sort of interdisciplinary kind of approach. Tumor spillage. Okay.
Great. So yeah, please, Dr. Gibbs, take over the next question, which would be, what would you be looking for in surgery, and how would that guide the decision to do adjuvant treatments like chemoradiation?
Yeah, so we would be looking for what the surgical findings were. What happened during that surgery? Were you able to take out that tumor completely without disrupting the capsule, without disrupting? Was there any spillage? And if so, was there any spillage throughout the entire abdomen, or was it localized to the area where you removed? When you sampled lymph nodes, were lymph nodes also shown to be positive at that particular time? And of course, from the pathologist, we really want to understand what kind of Wilms tumor is this? Is this a favorable or unfavorable? And now in the era of molecular and chromosomal analyses, what were the findings there with regard to sort of the 1P and 16Q? Was there any anaplastic histology? All of those things are going to be really important.
Exactly. So we have kind of two different scenarios we can quickly run through. So the first one is, let's say she's found to have a completely resected favorable histology Wilms, but did have a positive periaortic lymph node. What treatment would you recommend? And then the next slide asks, what if she instead were to have a peritoneal seeding, and how would that influence what you would do to your radiation? Perhaps Dr. Bronstein, would you like to answer?
Sure. So the issue with these tumors is that they tend to be very friable, which is why the surgical resection is very critical. And also there are certain indications for radiation, recognizing when radiation is used to augment local control for fear or frank evidence of seeding. And so if there is evidence of extension of the tumor outside of the actual renal parenchyma, outside of the capsule, that is generally an indication for radiation, including lymph node dissemination. But the actual intuitively margins that we use and the target volumes will change based upon the extent of that excursion outside of the primary tumor bed. So if there are lymph nodes involved within the periaortic region, we would include those periaortic lymph node basins in our treatment volume. But if there is, in fact, peritoneal dissemination, then we need to treat the entire peritoneal cavity, which is generally a very impressive target volume, as you're showing here across these four. I don't know if you have a poll, so maybe we'll do the poll and then comment on that.
But in that original case, without this peritoneal seeding, would have been really the flank in the periaortic region. And then as we're also answering this poll, Wilms is fairly sensitive to radiation, so the doses here are very low. So we would have likely gone to a dose of like 10.8 gray to that flank and periaortic region for the original case.
Okay, great, thank you. Yeah, so the majority of attendees answered that B would be the correct treatment volume, which is pretty reasonable. And, you know, it's sort of, I suppose, anywhere between B and C. Perhaps the panel can comment on why those two are reasonable and which one they would prefer.
I guess I would say C would be a bit more reasonable, just because we breathe and you want to get a little bit of margin on the diaphragm.
And I would agree, and just recognize that the abdominal cavity is contiguous with the pelvis, and so we're treating anatomically all the way down into the true pelvis below the obturators. These are traditional volumes that we would use to encompass the entire abdominal peritoneal cavity.
Yeah, and I would just also say that, you know, it is tricky between B and C. When I actually looked at it, I was like, whoa, which one is it? So this is not the most straightforward one. The diaphragm moves. So just in general in radiation therapy, we have to account for motion and especially internal motion that happens naturally, like when you breathe. So that's why C is the right answer. Also, when you're treating pediatrics with radiation, you always have to think of long-term side effects. So it's kind of tricky because the higher we bring that border, the more of the heart we're treating. And cardiac long-term side effects can be pretty bad from radiation. And so really it's a fine line. You want to make sure you're treating the entire abdominal cavity, but not treating more of that heart than you need to.
Great, thank you. So next is just a picture of the dosimetry of whole abdominal irradiation, which is a misnomer because it's whole abdominal pelvis. And it's pretty homogeneous using a field-on-field technique, but we can talk about that later during the rotation. So thank you all for going through this case.
Yeah, I think we'll, for the interest of time, we'll just stop there so that we have some time at the end for questions from all the students. For all the attendees, you can continue to ask questions in the chat, or you can raise your hand and we can let you speak if you'd rather ask questions to the panelists about any of the cases or anything in general. So I just want to go through some housekeeping before we open it up to the attendees. Just want to thank everyone for attending, especially our panelists for taking the time to participate in education during the current environment. We'll be sending out an email to all the attendees just with the email addresses of our speakers if you want to reach out to any of them individually after the session to learn more about their program, or if you have additional questions. We'll also send out the survey link and an email afterwards. Please fill it out to get feedback on the session so we can improve these going forward. Next slide. And then our next session will be in a couple weeks. It'll be head and neck, but check out our website to register for future sessions. And then I'll turn it over to Jenna.
Can we go to the next slide? So I just put in the chat box, there is a list of contacts for people around the country of physicians who would love to talk to you if you're interested to talk with them. So please reach out to them. And I know that they would be more than happy to discuss probably anything with you. Next slide. Our next session will be on July 9th, same time. You will have to sign up again on the red cap, and it'll be on head and neck. And so we'll have attendings from University of Pittsburgh, University of Iowa, San Diego, and Cleveland Clinic. And then the next slide. And this is just a plug for, there's an ACRO webinar. It's a Q&A webinar for medical students on July 16th from 6 to 7 p.m. So you can go onto their website and register for that if you're interested. So with that, we'll open up to questions.
So Zach White has a question for all the speakers. What drew you to specialize in CNS and our peds, and when did you decide? Maybe if the panelists can share a little bit about themselves.
I'll answer that. So I did a fellowship at University of Michigan, and I really thought I was going to be a genitourinary radiation oncologist. I arrived here at UAB about 22 years ago, and we started a prostate clinic. And it was very good clinical program, but the opportunity for clinical research and clinical trials was really big in the other part of my practice, which was brain tumors. And I got involved with Ed Shaw from Wake Forest, and involved in the Adult Brain Tumor Consortium leadership. And it has been intellectually interesting to try to study the types of problems that these particular patients have. So that's been my journey.
Can I share something?
Yeah.
Well, it'll be quick, but you know, some people had asked, well, why do you like brain tumors? Isn't it kind of sad? Because, you know, they all, well, not they all, many of them are GBM patients, but you know, you're gonna have some of them like that, and they are the most touching patients that you will meet, because there isn't a even more important time in life that sometimes than being able to walk with that patient and their family in a difficult time. And when a patient and their family ask you as a radiation oncologist, will you be my hospice doctor? It's kind of an honor, because they trust you, and they know that you've developed such an intense relationship with them. And you know, that's not all patients in CNS, but it's kind of critical work that you're doing. Even if you can't cure a GBM, you can really be an important person in their life. And that's one reason why I love CNS.
I think I might say a group answer, but Karen can kind of chime in. I suspect that Sarah Donaldson has a lot to do with our choices to pursue, you know, certainly pediatric and pediatric CNS radiation oncology. She's an amazing role model, and she's a leader in our field. And she helps you to really see talents that you might have that you might not have thought yourself. So that was the case for me. And of course, radiation oncology I found through research, but I think, you know, the CNS and pediatric CNS in particular, I think I have Dr. Sarah Donaldson.
So to add to what Dr. Gibbs said, mentors obviously always play a huge role in your life and the path you end up taking. So for me, it was Dr. Gibbs was one of my mentors. And so I wanted to be like her, so peds and CNS. Really, and obviously Dr. Donaldson, Dr. Hoppy, and a lot of people at Stanford really influenced my choices. But also just the pediatric population, just like Dr. Page was pointing out about some people look at you like, why would you want to take care of those patients? It's so tragic. I look at it the other way. I think there's nothing more fulfilling than taking care of kids. I think it's honor and privilege, and kids are so much fun. It makes going to work really fun every day. And so that's kind of how I got to where I am.
And I would echo that as well. The importance of mentorship is critical, but also we do see it as a privilege. And we recognize in the patients that we treat, many of them will have advanced disease, and many of the interventions that we do are not curative in nature. They're really focusing on extending quality of life, giving the patients their ability to be their best for the time that they have. And I think that can be very, very fulfilling for most of us.
Ditto. I could share one story. I'll share two. You know, yesterday we were discussing a newly diagnosed GBM. My resident is sitting next to me. We're doing this by WebEx because we're in the COVID world, right? And she asked about what's going to happen to her kids, what's going to happen to her family, how much time does she have left? And he shed a tear, and her response was one of, hey, here's this empathetic young doctor that he's involved in my journey. And you get this in this population in a way that you don't get in any other population. So when a patient, the second story, a patient last week sent a picture of his son. They passed away last Tuesday. He was sending a picture for us before he passed away of him holding up a little heart sign maybe 3 days before. That was a joy. He lived beyond what they thought. They got to say goodbye for 1.5 years for a diffuse midline glioma. And so I said, this is not a time for a tear. This is joy. They've invited us into their family. We get to be part of their journey. And you can't do that the same in very many tumors, right? This is a unique opportunity. So ditto.
It's very inspiring. Thank you to everyone, to all of our panelists. If there are, I see that there are some more questions, but I know some of these panelists would be more than happy to talk with you over email. I specifically want to say thank you to Nav, to Jacob and JP for moderating the session. So thank you, and we hope to see you on July 9th.
Great, thank you all. Bye.
Thanks, everyone.
Thank you.
Thanks a lot.